Your doctor may perform a percutaneous endoscopic gastrostomy, or PEG, to insert a feeding tube into your stomach if you are unable to take food by mouth for an extended period of time. Digestion of food begins in the mouth. When you swallow, food is pushed down into your esophagus, a muscular tube that carries food to your stomach where it is digested. From the stomach, food travels to your small intestine, where digestion continues and nutrients are absorbed into the bloodstream. Your doctor may require a PEG feeding tube if you cannot eat, digest, or absorb food due to esophageal cancer, oral surgery, or stroke, major surgery, trauma, burns, or anorexia, inflammation of the pancreas, or radiation therapy or inflammatory bowel disease affecting the small intestine. Before the procedure, you'll receive a sedative through an IV to help you relax. A local anesthetic will be administered at the site on your abdomen where the PEG tube is to be placed. The most commonly used PEG placement procedure is the pull method. During this procedure, your doctor will insert a lighted endoscope through your mouth and thread it down your esophagus and into your stomach. A camera attached to the endoscope will produce images of the inside of your stomach, which will be displayed on a video monitor. Next, your doctor will insert a needle through your skin into your stomach at the location where the PEG tube is to be placed. While doing this, he or she will use the endoscope to locate the end of the needle inside your stomach and encircle it with a wire snare. Your doctor will then pass a thin wire through this needle into your stomach, attach the endoscope to the wire, and pull both the endoscope and wire out through your mouth. At this point, there will be a thin wire entering the front of your abdomen into your stomach and continuing upward and out of your mouth. Your doctor will attach the PEG feeding tube to the wire outside of your mouth. By gently tugging on the other end of the wire, he or she will pull the tube back through your mouth and esophagus and into your stomach. Your doctor will continue to pull until the tip of the tube comes out of the incisions in your stomach and abdomen. A soft round bumper attached to the portion of the tube that remains inside the stomach secures it in place. The outer portion of the tube will be secured with a bumper as well, and sterile gauze will be placed around the incision site. In the alternative push method, your doctor will begin in the same fashion by using an endoscope to guide a wire through your abdominal wall and into your stomach. But instead of pulling the PEG tube through your mouth, he or she will push it directly into your stomach over the wire. After your procedure, you will continue to receive fluids through an IV for 1 to 2 days. Once there is evidence that your digestive tract is functioning, you will receive clear liquids through the PEG tube. If clear liquids are tolerated, you will receive a tube feeding formula through the PEG tube.
The following is a demonstration of the skill validation abdominal assessment and tube feeding via a PEG tube or a G-tube. Gather the appropriate supplies. You will need the appropriate tube feeding per doctor's order, tap water, 60 milliliter catheter tip syringe, 3 240 milliliter graduated cups, a bath towel, emesis basin, stethoscope, and pH paper per hospital policy. Wash your hands before entering the patient's room and provide for privacy. Introduce yourself to your patient and explain what you will be doing. Check the ID band name and number, compare with the order sheet, read it out loud, and have the patient state his or her full name. Check the doctor's order for the ordered tube feeding. Assemble the supplies on the bedside table. Pour desired amounts of flush solution and tube feeding. Pour 30 milliliters of flush, tap water, 60 milliliters of flush, and make sure to get down at eye level to verify the amount when measuring. Measure the amount of ordered tube feeding in your middle cup. Put the head of the bed down to 30 degrees. Do not put a patient who is receiving a tube feeding flat in bed. And continue to pour desired amount of tube feeding. If necessary, raise the height of the bed to a comfortable working position. Uncover the abdomen. Inspect the abdomen first, looking at contour, looking for distension or any scarring. Ask the patient the date of the last BM and usual bowel habits. Next, visually divide the abdomen into 4 quadrants. Swab the stethoscope with alcohol at the diaphragm. With your stethoscope, listen or auscultate in all 4 quadrants, listening for the presence of bowel sounds. If exposure to blood or body fluids is expected, don work gloves. This patient is clean and dry, and work gloves will not be necessary. Lightly palpate the abdomen in all 4 quadrants, assessing for any tenderness, lumps, or bumps in the abdomen. This completes the abdominal assessment. Position the patient in semi or high Fowler's position. Don your work gloves. Place a towel on the abdomen to protect the patient and bed from any spillage. Verify the placement of the PEG tube. Visually inspect the tube length and that it is intact in the abdomen. Unclamp the end of the tubing, pinching the tube just below the connection to prevent spillage of gastric contents. Attach a catheter-tip syringe to the end of the PEG tube. Aspirate gastric residual, assessing color, consistency, and amount. If gastric residual is less than or equal to 100 milliliters, return the residual. Gently return all but a scant amount, saving for a pH test, and reclamp your tubing. Test pH according to hospital policy. Take the syringe plunger off and gravity flush the PEG tube with your 30 milliliters of water. Pinch the tube between to prevent air from entering the tube. Administer tube feeding by gravity via the PEG or G-tube slowly as prescribed. The rate that the fluid is administered can be adjusted by rising or lowering the height of the syringe. Allow all of the tube feeding to enter by gravity. Flush the tube with 60 milliliters of water. And reclamp your tubing. Leave the head of the bed elevated after feeding. Discard your work gloves and cover the patient up. Lower the height of the bed if it was raised. Wash your hands. And document abdominal assessment, presence of bowel sounds, placement check, amount of residual, amount of flush, type of tube feeding, and any patient complaints.